Hello, my friends. This is Dr. Atkinson, and today we are going to talk about one of the most important electrolytes in the human body, potassium. Potassium is small, but it is mighty. It controls how your muscles contract, how your heart beats, and even how your nerves send messages. Without the right amount of potassium, the body's electrical system starts acting like a house with bad wiring. The normal range for potassium is 3.5 to 5.0 milliequivalents per liter. Most of your potassium lives inside your cells, not in your bloodstream. That is why even small changes in the blood level can mean something big is happening inside your body. Part 1. When potassium gets too low, hypokalemia. Hypokalemia means the potassium level has dropped below 3.5 milliequivalents per liter. It can happen for several reasons, but let's start with the most common. First, you can lose potassium through your digestive tract. Vomiting, diarrhea, gastric suction, or draining tubes can all pull potassium out of the body. Second, you can lose it through your kidneys. This is common when taking diuretics, especially loop or thiazide types. Third, you might not be eating enough potassium. This can happen in starvation, fad diets, or being nothing by mouth in the hospital without proper intravenous replacement. Fourth, potassium can shift into the cells. This happens in metabolic alkalosis or after giving too much insulin. And finally, magnesium deficiency can make you lose potassium faster, and heavy sweating can do it too. What happens in the body when potassium drops? Potassium is in charge of keeping nerve and muscle cells ready to fire. When it gets too low, the signals slow down or misfire. If potassium drops to less than 3.0, things can get dangerous. Your breathing muscles may weaken, or your heart rhythm may become life-threatening. What does hypokalemia look like? Muscles, weakness, cramps, fatigue, or tingling. Heart, an electrocardiogram may show flat or inverted T waves, a depressed ST segment, or a U wave after the T wave. Digestive tract, poor appetite, nausea, vomiting, constipation, or even a paralytic ileus. Kidneys, passing more urine than normal, especially at night. Endocrine, trouble handling blood sugar because the pancreas releases less insulin. How do we confirm hypokalemia? A blood test will show potassium less than 3.5. A 24-hour urine collection can help tell where the loss is coming from. More than 20 milliequivalents per day means the kidneys are losing it. Less than that usually means it is being lost from the gastrointestinal tract. Treatment of hypokalemia. If the drop is mild, oral potassium is usually enough. Potassium chloride or potassium gluconate are common. If it is severe or the patient cannot take pills, we give it intravenously. And let me be very clear here. Potassium is never given as an intravenous push. That can stop a heart in seconds. It must be diluted in fluid, run on a pump, and given slowly. The maximum rate is 10 milliequivalents per hour in a regular vein or 20 milliequivalents per hour through a central line with heart monitoring. And of course, we treat the cause, stopping the vomiting, slowing the diarrhea, or replacing magnesium. Nursing priorities in hypokalemia. Identify patients at risk like those on diuretics. Monitor their intake and output. Watch the electrocardiogram for rhythm changes. Assess muscle strength and safety. Weak muscles mean higher fall risk. Teach patients to eat more potassium-rich foods if not restricted. Bananas, oranges, potatoes, spinach, tomatoes, meat, and dairy. And for those on digoxin, remember that low potassium makes them more likely to develop digoxin toxicity. Here, part 2. When potassium gets too high, hyperkalemia. Hyperkalemia means the potassium level is above 5.0 milliequivalents per liter. This can happen for a few reasons. First, the body may not be able to get rid of potassium. This happens in kidney disease or kidney failure, or when taking potassium-sparing diuretics. Second, you may be getting too much potassium in your diet or medications, salt substitutes, supplements, or too much intravenous potassium. Third, potassium can leak out of cells into the blood. Acidosis, severe injuries, burns, infections, or tumor breakdown can do this. And sometimes we see a false high, called pseudo-hyperkalemia, from blood being hemolyzed in the lab tube or drawn from above an intravenous potassium infusion. What happens in the body when potassium is high? High potassium changes the electrical charge across cell membranes, making muscles and nerves too excitable at first and too weak to fire at all. When potassium gets very high, over 7 or 8, the heart can go into dangerous arrhythmias and stop. What does hyperkalemia look like? Early signs: muscle twitching, cramps, tingling, nausea, diarrhea. Heart: on the electrocardiogram, you may see tall peaked T waves, a short QT interval, and later a prolonged PR interval, loss of P waves, and finally ventricular fibrillation or asystole. Muscles: weakness progressing to paralysis. Confirming hyperkalemia. Always retest if the result is unexpected. Check arterial blood gases. Acidosis can be both a cause and an effect. Chas-Char's treatment of hyperkalemia. For mild or non-urgent cases, stop high potassium foods and supplements. Stop potassium-sparing diuretics. Give potassium-binding resins like sodium polystyrene sulfonate, K-exolate, or padaromer to remove potassium through the stool. For emergencies, intravenous calcium gluconate to protect the heart. Remember, it does not lower potassium, but it buys time. Regular insulin with hypertonic dextrose to move potassium back into cells. Sodium bicarbonate, if acidosis is present, also shifts potassium into cells. Beta-2 agonists like albuterol, which also shift potassium into cells. Loop diuretics like furosemide to flush potassium out through the urine. Dialysis for severe or kidney-related cases. Nursing priorities in hyperkalemia. Monitor high-risk patients closely. Kidney disease, burns, massive tissue breakdown. Watch the electrocardiogram for changes. Monitor labs: potassium, blood urea nitrogen, creatinine, blood sugar, and blood gases. Teach patients about potassium restriction. Be safe with intravenous potassium. Always use a pump, verify the rate, and never give it as a push. Final thoughts. Potassium imbalances can sneak up on you and become deadly in a short amount of time. As nurses, we have to keep an eye on at-risk patients, recognize the early signs, and know the right interventions, because catching it early can be the difference between a stable patient and a code blue.